Hey guys, welcome to Curbside to Bedside. What you're about to hear is an interview with Dr. Jeff Jarvis. We don't get to a formal introduction until about a quarter of the way through the podcast. We interviewed him at the St. Elizabeth EMS conference in Covington, Kentucky, and as soon as he came into the room, we dove into clinical topics, and it was so good we wanted to capture everything. And as you'll see, Dr. Jarvis made it a little difficult to get a formal introduction in, and we loved every minute of it.
So I'll tell you, we've been using the King Vision for, 5, 6 years now. And I love it. We've taken DL off the truck. We are demonstrably better with the VL than we are with the DL and with that hyperacute ankle channeled blade. So I am all in on that. But I'm really getting a little tired of asking nicely and begging and getting down on my knees and sobbing and, showing little kittens to the King Vision people, asking for them to please let it record. Nothing. So I've had it. We're going to do a trial with the AirTrack.
Really?
Yeah. And it's specific. I love the King Vision. I just need recording capability. Yeah. I want to be able to see what my medics are seeing.
And that was the best part about having that Intebrite, because if we set it up to wherever you opened it, it started recording immediately.
Mm-hmm.
So, and you could also take stills in between.
Yeah.
Like if you wanted to do a secondary confirmation or something like that. But every time you had an intubation attempt, you'd actually take it out, take it to your supervisor, and they would download the data. And then they were building a compendium of every intubation attempt.
Yeah.
So legally it was great. And then for QA purposes, like every month or whatever, we could go back and show all the different innovations that have been done.
We want to use it for a couple of things, and we're still struggling with what are we going to do during the trial, and if we adopt it, what are we going to do with the files? And ultimately, the side I came down on is we're going to upload it to the chart just like a monitor file. Mm-hmm. And people can say, well, that's discoverable. Yeah.
Yeah.
So is an EKG. But if we intubate the esophagus and we kill them, that's discoverable. Quite honestly, if we intubate the esophagus, don't recognize it, leave it in there and kill them, we should have it discovered. Almost what we should do is just write a check because we were wrong. And so we need to know that. It would be nice if there were a way to upload a file, and we use ESO. So
we use it as well.
That's my suggestion to them, is they have a way of uploading files just like you would normally upload it, but you designate it as quality improvement. So then it gets marked as quality improvement. And most states have legislation that says quality improvement documentation is protected information. So when someone files a Freedom of Information Act, or when they ask for, they subpoena that information, you don't get the quality improvement stuff. It's held back. I don't know if they can do it. In the meantime, I just said, I don't care. If we goose it, then we need to own that.
That's
so
a nice,
we upload it.
The QI protection is a nice middle ground, but I'm more of the fact that if you intubate the esophagus and you don't recognize it, we kill someone, we deserve to have our asses handed to us.
Absolutely. Yeah.
That's
we're not in the business of hurting.
Levels.
Yep, absolutely.
Unfortunately, that typically falls back on the provider. There's something to be said for that, but in my mind, it's a system failure too.
Oh, I think it's absolutely a system failure. I mean, my medic, I work with, I think, some of the best medics in the world, but they have one flaw, and the flaw is that they're human.
Yeah.
And humans turn out to make mistakes. And I think I'm a little more human than other people because I make more mistakes than other people. The catch is I just try to learn from it.
Yeah.
So, yeah, we all make mistakes. That's kind of part of it. So our objective is to build a system that doesn't allow you the opportunity to make that mistake.
Our medical director would say you just haven't been put in the right position yet if you don't make mistakes.
Yeah. So. You haven't been challenged enough.
So I hear that. You've probably heard people say, I've never missed an IV or I've never intubated somebody. Okay, well, there are two possibilities here. Number one is that you haven't done many of them. And number two is that you're full of shit. And I got my money on number two. Right?
Yeah.
I have missed plenty of IVs. I've missed plenty of intubations. So I was on a call maybe last week. Tried to start an IV with a medic that I was in the process of clearing. I come back to the office afterwards and I missed it not just once, but twice on a young, healthy 17-year-old. I mean, there's no excuses whatsoever. And there's a meme. It has Obi-Wan Kenobi and it says, Jarvis, no IV Kenobi. Great. That did not take nearly as long as I was expecting.
No, it's immediate.
Exactly.
It's funny.
You can try to start, but I'll go ahead and come in for some more plugs for Texas.
Can you introduce yourself?
We're like a whole other country.
Do you like barbecue?
Basically secede.
I'm actually a vegetarian, so Well,
are you really?
A pseudo-vegetarian, yeah.
Do you eat fish?
I do. So I fish and hunt. So my rule is I'll actually eat fish now because I'm on the road so often. It's hard to not eat meat. But my rule from the time I started was I will eat anything that I kill or catch.
Okay.
So I eat the hell out of some elk. That's what my freezer's full of right now.
So Dr. Jarvis is a medical director for Marble Falls and Williamson County.
Williamson County, yep.
In Texas. And you're also a paramedic.
I am, yeah. So I actually started my career as a paramedic in Texas A&M EMS. We're a volunteer EMS agency, serving the campus community. So I started there. I went to Houston Community College while I was going to A&M. I got my paramedic and got a job. My first paid job was as a paramedic for Williamson County EMS. I did that until I went to grad school in New York. I got a master's in EMS. Came back, worked as a paramedic and as an educator and as a state training officer for about 10 years and then went to medical school. So, and I've kept this year will be 30 years as a paramedic.
That's awesome.
That's impressive.
Was it just the whim? I think I'll go to medical school now. Because that's a really awesome full circle kind of thing. So there are two main reasons. One, I had been very involved in state legislation in Texas that created a licensed paramedic. And the idea behind that was it would be based on education. You have to have an associate's in EMS based on that curriculum. And our legislature meets every 2 years, which is probably 2 years too often. And over the next 3 or 4 legislative sessions, I just saw them water it down and water it down and water it down. And I got very frustrated with the sausage making, and wanted to do something else. And about the same time, I got talked into writing a pharmacology chapter for the new paramedic curriculum. Okay.
And as I started looking at it, I realized I didn't have the chemistry background to make me feel comfortable writing it. So I went back and started taking to take organic chemistry, which is what I wanted. You have to take inorganic chemistry. So I went back and started taking those. And in the process of taking those, I realized I love science and said, well, what the hell? I'll just go to medical school. That will allow me to be an EMS medical director.
And you pretty much, by that point, had all your undergrad requirements met to go to medical school, right?
Yeah, I already had a master's degree.
Okay.
I didn't have the science prerequisites, though. I was a psychology major, which is another way of saying the path of least resistance. I majored in EMS, and A&M was rude enough not to offer that as a degree. So I just had to get a degree from something. So I went back and did all of my science prereqs and then went to medical school.
So we've got you here today. That's kind of the reason we wanted to bring you on the show.
So I can promote Texas tourism?
Is for your wealth of knowledge and the work that you do on delayed sequence intubation. You recently came out with a paper that encompassed a clinical bundle that you implemented. Was it just in Williamson County?
No, Marble Falls does that also.
Marble Falls.
Yeah. So Williamson County is my full-time job. And then I'm a part-time medical director for Marble Falls.
Okay.
But we share the same protocols, the same training.
Okay. So this was a clinical bundle, not just for delayed sequence intubation, but it involved some other components to make it successful. Yeah,
absolutely. And it's really interesting. I started writing this article, and it's not, I call it an article. It's a study. It's a retrospective study. And I submitted the first draft of this to Annals of Emergency Medicine, and it got kicked back. And my senior editor was Dr. Wang. Henry is a great guy and has really helped me a lot. And one of the things he said is, listen, you think this paper is about DSI, but it's not. It's about a bundle of care. So what the fundamental structure of the paper is, it is a retrospective chart review set up in a before and after intervention. So we looked before we implemented this thing that I was calling DSI, and then we trained on it and we compared the results after we implemented it. And I said, this is about delayed sequence intubation. And Henry said, no, it's not. And I said, yes, it is. And he said, no, it's not. And we went back and forth for a while. And I said, okay, Henry, I'll bite. You're a smart guy. What is it about? Well, he said, it's a bundle of care. DSI is one part. You also have mandatory positioning. You have apneic oxygenation. You have requirements, what I call goal-directed saturations. You refuse to let them intubate if they're not pre-oxygenated. All of that was not in place in the pre-section. Therefore, this isn't DSI. This is about a clinical bundle. And I went, damn it, you're right. So I rewrote the title. So it really is about that bundle. More importantly, I think I was very focused on calling it DSI, but it's not. It really is more about a clinical bundle or a toolbox of tricks to use to avoid peri-intubation hypoxia.
So what did this bundle do for your patients after you implemented it?
So our primary outcome in the paper is the proportion of patients who had peri-intubation hypoxia. And we define that as oxygen saturation less than 90 anytime between 1 minute prior to pushing the paralytic and 1 minute after pushing the paralytic. So if they had an oxygen saturation less than 90 anywhere in that period of time, we said that is a peri-intubation hypoxic patient. And we looked at the proportion before and after. Our proportion was 44% in the before group and 3% in the after group. So we had a decrease of 40, a little over 40%, 40.5, I think.
That's pretty dramatic.
That is
it really was.
Statistically significant.
Yeah, it is. And actually, I'll tell you, so here's the little, I can't help putting my nerd hat on and explaining this. If you look at the data tables in our paper, one of the things you will not see are p-values.
I noticed that. It was just a confidence interval.
Just a confidence interval. And I was watching a journal club somewhere for I think it was an EMS fellowship, and they were discussing it. And they brought a statistician on, and the statistician said, well, see, this is one of the weaknesses of the paper. They're clearly hiding things because of the outliers. And the way they're hiding it is by not offering a p-value. Dude, put the doobie down. I had p-value. I know how to do p-values. It's not hard. Stata spits those puppies right out. They were in my initial draft. Annals is anal retentive about their methodology. They actually have a methodology editor. And they're that way for a very good reason. P-values are misleading. And he said, listen, get rid of the p-values. Just show the confidence interval. A confidence interval will show you significance, but it also shows you effect size. And I think that's a lot more
informing than just a p-value.
It really is. So what we measured was the difference between before and after. So if we're going to say there is a significant difference in the before and after group, we'll measure that. And we found negative 40%. So the after was 40 percentage points less than the before. Well, is that significant? The way you figure that out is you look at the confidence interval. And if the confidence interval involves both negative and positive numbers, then the difference either could have been negative or positive, meaning before could have been better or after could have been better. But our confidence interval was entirely negative, and I believe it went from something like 30 to 60% better. So there's no doubt that is all on one side, showing that after is definitely better. Yeah. So it shows not just that it's significant, but it shows the effect size. So that's the reason we don't have it in there. So yeah, it is a pretty impressive difference. And I think what it shows is that if you pay attention to good pre-oxygenation and think about this, it works. It decreases things. So I think the main takeaway is that the bundle we used makes sense. We looked at the literature and came up with everything that you should be doing on an intubation. And we said you shall do that on an intubation. So it's not surprising. All of those component parts have been shown to improve pre-oxygenation and decrease desaturation. So it shouldn't be surprising that if you actually do it, it decreases desaturation. But it is nice to actually be able to put it together and say, look, here's the evidence that this works.
I think we'd like to learn from your success. Can you talk about each individual component and how those tie together?
Absolutely. So the first component is, and in no particular order, because you have to do this on everybody. So in the order that I happen to remember it, first off is positioning. And to set the table here, we are not talking about patients in cardiac arrest. These are only non-arrest patients. Now, whether that means they were in arrest and now they're a post-arrest patient, that's all right. They would count. We would do this process on those patients. But if they're actively in arrest and we're doing compressions, this doesn't count. It would be a little challenging. So the first thing is positioning. So we elevate the head of the bed, and we put them into an ear to sternal notch position. And an ear to sternal notch position sometimes gets a little challenging to visualize. Mm. Knowing our audience is primarily EMS people, these are my people. I know them. I've seen them at the bar. Let's be honest about this. So the way I visualize this is you get a full pint. there you are. First pint of the night. It's full to the brim. Now, if you just sit back with your head in neutral position and try to drink it, that beer is going all down your chest and your abdomen, and that's just alcohol abuse. We can't do that. No, nobody does that. What they do is they lean their head forward so they can sip the first bit of beer and not get it down their chest. Well, guess what? That's ear to sternal notch position. When you just reach forward to take that first sip, I call that pint sipping position instead of ear to sternal notch, because that speaks to me. That's what I like to do, so that I can visualize that. So we do that on all patients. So positioning is number one. And both of those things, by the way, ear to sternal notch and head of the bed elevated, do several things. They improve intubating conditions, and they prolong the amount of time it takes for a patient to desaturate while apneic. And I have the references both in the paper and the presentation that I do. Next, we do apneic oxygenation. So we do that with just your run-of-the-mill nasal cannula, not the Untitled CO2 prongs.
We talked about that in a previous podcast.
Good. Just because you can plug it into oxygen doesn't mean it gives oxygen. Yeah. It took me a while to figure that out. That was kind of humiliating when I figured it out. I'm like, oh. So apneic oxygenation at a flush rate. Well, a flush rate is uncomfortable. Well, not after you've been given ketamine. So we put a nasal cannula on, and we actually put a nasal cannula on top of or underneath, depending on how they set it up, the Untitled CO2 prongs.
Okay, so you do both.
We absolutely do both. And then we transition from the nasal prongs over to the inline prongs with both BVM and intubation.
So for the entire time before you place a tube, the patient is on a high-flow nasal cannula.
Before they get ketamine, they're on a nasal cannula. It may not be high flow yet. And as soon as they get the ketamine, then we crank it up.
So you're still, before they get ketamine, you're treating them as you would any patient.
Absolutely.
And then you realize the need for intubation, and
then they get so let's just say you have a patient with pneumonia.
Okay.
And they're breathing 30 times a minute. Their GCS is dropping because they're hypoxic. They're sick, they're hypotensive, and we'll address the let's just say magically we're doing something about the hypotension to avoid distraction. Okay. So we put them on an onward breather, and that's not cutting it. So then we switch them over to BiPAP, or we use CPAP, for the time being. So we put them on that and realize that's not cutting it. We're going to need to go ahead and intubate them. We'll, at that point, put them a nasal cannula on, and we would have already had the Untitled CO2 prongs on. Apply the oxygen at, 6 liters, whatever they tolerate. And then we give them ketamine, and we'll switch from the CPAP back to another version of CPAP, basically a BVM plus PEEP. And we can talk about that in a bit. We always have the nasal oxygen on. And that way, once they get the ketamine, we crank it up to flush rate, not just 12 or 15 or whatever the cylinder goes to, but as far right as you can turn the thing. And that's particularly evident when you're in the back of the truck and have the little Christmas tree thing. Keep turning that knob. Once the little ball is at 15, keep going. And you may not see the ball go up anymore, but you can hear the difference. Just to this really high-pitched screaming. You want the screaming. So get that oxygen going as much as you can. It makes a difference. So apneic oxygenation. The next thing we do is we do a special seal. And by special, I mean one that works, as opposed to what we're taught in EMT and paramedic school. So stop using the one-hand clamp. It doesn't work. It may work for something, but effective ventilation isn't it. This is not the operating room. We're not using anesthesia circuits. And honestly, we're just not very good at it. So do a two-handed seal. And we use this as a two-person operation. 2 hands, thumb down, with your fingers under the mandible, lifting the mandible up into the mask instead of pushing the mask down onto the mandible. One of the reasons that a C-clamp doesn't work is if you bag and air goes out the face, our inclination is we just push harder. Mm-hmm. And what we're doing is actually obstructing the airway. That's not working at all. So 2 fingers down, 2 thumbs down, lift, don't pull. Use an adjunct if you need, nasal airway, oral airway, if they tolerate it. And when you're doing that, make sure that you have high flow going both through the nasal cannula and the BVM. So make sure your reservoir is up, and make sure you have PEEP attached and on. So at a minimum of 5. And what you're doing there is making CPAP. So then we get the saturations up to 93%, or actually it's higher than 93. So above 93 or 94 or higher. That means the same thing. So 94 or higher, And we actually have a stopwatch, and we hit the stopwatch. And this is what we call goal-directed oxygen saturation. We maintain a sat of 94% or higher for 3 minutes. Once you've hit 3 minutes, now you have achieved good, adequate pre-oxygenation, which is denitrogenation, and then you can move forward by giving the paralytic. Once we do that, they go down, we reset. We use rocuronium right now, pending the next drug shortage. And we reset the clock for 90 seconds because one of the reasons we were missing intubations is we were trying to intubate before full relaxation. Okay, let's just wait 90 seconds. If they're adequately pre-oxygenated and you're using apneic oxygenation, the majority of patients will tolerate that without any intervening ventilation. Yeah, they're going to be apneic, but that's all right. That's why we do the pre-oxygenation. Now, if the SATs drop below 94%, then we abort the attempt and we re-oxygenate. Now, in this case, they're paralyzed because we have already given the rocuronium. So we'll go ahead and gently ventilate until the SATs come back up, and then we'll proceed. So those are the main components. We do positioning, apneic oxygenation, a two-handed BVM seal with PEEP, maximum oxygen flow, and goal-directed saturations so that we will not intubate if the saturations are 94 or less, and they have to be there for 3 minutes. So that's the bundle.
During the dissociation phase with ketamine,
prior to paralytic,
okay. If you can't get their SATs above 94%, then you still push the paralytic?
No, correct.
What do you do with that? You either
manage the airway without an ET tube.
Without an ET tube.
Right. Now, you have options, and one of those options may ultimately involve a paralytic, but it does not involve an ET tube. So let's run through a couple of scenarios. So you have a patient that you're trying to pre-oxygenate. You do all of this. You push the ketamine, but you're not able to get the saturations up. Okay, so intubation is off the table. You can place an iGel, and if there is masseter tone that is preventing you from placing the iGel, then by all means use rocuronium. So we'll do that and then place the iGel. And the reason we do that is because you can place an iGel faster, and if they are not adequately oxygenated, their rate of desaturation is much, much faster than if they were well oxygenated. So if you can't get them saturated, you're in that danger zone or you're already hypoxic, you're going to desaturate at an unbelievably fast rate, way faster than I think we really realize. And before you know it, as you're dinking around with the laryngoscope, the patient's going to be in the 60s, in the 50s, in the 40s. And then you're in the peri-arrest period, and they will arrest faster than you know it. That's actually, we had a case where that happened, and that's what instigated us to implement this process, to look at what we were doing. We talked earlier about adjust culture and how we change the system to prevent you from making a mistake.
Absolutely.
So we had a case where we had a woman that was having respiratory distress, respiratory failure. CPAP wasn't working. We had 3 experienced paramedics that I would allow to take care of my family any day. And they went in to intubate, and the SATs dropped and dropped and dropped. And they got so focused on intubating the patient. Patient went into cardiac arrest. They aborted the attempt. Second attempt, got the tube in, SATs came up, pulses came back. Unfortunately, she had permanent neurologic, just a devastating injury. And that's something we did. And so we said, this is not acceptable. And it's not, my reaction wasn't to go cut the heads off of those medics, because I think that was my fault as much as it was theirs. We had a system that allowed for that. And I probably made that problem worse by focusing on first pass success. So we backed up. We looked to see how often it was happening. Oh my God, it was happening a lot. We had about 3% of our intubations ended up in peri-intubation arrest. Now, it turns out that seemed really high to me, but that's what the literature says. And that literature includes emergency department intubations. It's not just in the field. Dr. Mort has sort of the classic paper there. It says 2% of all emergency department RSIs end up in cardiac arrest.
Wow.
So it's not an unusual problem.
Did this increase your first pass success rate?
It did, but not statistically significant.
Okay.
Yeah.
I know that it did shorten the time that it took your paramedics to actually place the ET tube.
So it did. It cut it roughly in half. Again, not statistically significant. But when you're dealing with intervals of 1 minute or 2 minutes, you just ain't going to get the statistics. So Annals, again, methodologically pure, said we want you to use whole minutes and we want you to measure the difference in median and interquartile. And when you do that, the specific test that you use, I did exactly what was methodologically pure, and it doesn't show a statistical difference. But the median intubation duration prior to this was 2 minutes. It was 1 minute after.
So it cut it in half.
It did. Not statistically significant, but I would say clinically significant.
I would too. Why is that?
Absolutely.
So it's really interesting. We talked a lot about this. If you look at some of the things, the way our military trains on going in to clear a room, for example, our SWAT teams do the same thing. They don't train to rush and get in a frenzy and do things as fast as you possibly can, because they realize if they focus on rushing, they start to make mistakes and people get into trouble. So what they do is they teach you to be very methodical and go slow. And if you go slow and train slow, you end up doing it faster and without mistakes. So when I sent a poll out, and I actually asked, I said, hey guys, we seem to be intubating more people. We're doing it quicker and with less hypoxia. Why is that? And they said, well, with this process, we feel more confident that the patient is not going to desaturate. And by the way, you convinced us that desaturation is bad and it's common and we should avoid it. So we're paying more attention to it, but we're definitely more confident. And it turns out we're just better at it. And you could also say that we're now enforcing the positioning. The positioning increases, even with a hyperacute angled blade, it increases the view and your ability to intubate.
That was one of the questions I was going to ask.
Yeah, I think it is important. I will absolutely grant you that if you have a patient, let's say this is a trauma patient, and for whatever reason, you've convinced yourself you can't elevate the head of the bed. I'm not sure that's true, by the way, but let's just say that you've convinced yourself of that. It is more challenging to get a good view with DL without the patient elevated in an ear-to-sternal notch. Yeah, it's more challenging. Clearly, you can do it. That is easier with a hyperacute angle blade, no doubt. But it turns out if you put them in proper positioning, it's still easier yet with a hyperacute angle blade.
With trauma patients, did you still put them ear to sternal notch? No.
Yep.
Were those included in the study? Mm-hmm. Oh, they were?
Yeah.
Okay. Traditionally, I think
and I'm sorry, let me go back. I want to address the trauma. So this process also increased. It added time. It added about 10 minutes.
On scene.
On scene. Oh my God, you're adding on scene time. Yes, we are. I will own that and tell you I don't give a shit.
Absolutely. Thank you for saying that.
Absolutely. What I want is for us to take care of the patient and get the patient what they need. If this patient is hypoxic, what we need to do is fix that hypoxia. Now, if they're hypoxic because they have a head full of blood, ultimately we can't fix that. So we need to get them somewhere that can fix it. So in trauma patients, we extrapolate out to all trauma patients from traumatic brain injury because that's where the evidence is best. We still say, look, an extra 10 minutes on scene probably is not good. So you should get them off scene. Try to do this en route. And that presents some pressure and it makes it a challenge. We have to walk and chew gum at the same time with this. We have to minimize our scene time, get to definitive care rapidly with these trauma patients, and we have to prevent hypoxia. The one thing we know is that your odds of death with a traumatic brain injury with one episode of hypoxia is 6 to 7-fold higher than without. Okay, that's bad. That's not what we signed up to do. So we have to both prevent hypoxia and get the hell off the scene. Sometimes that means not intubating. So our medics, and I don't tell them what to do. I don't say you cannot intubate trauma patients. I don't say you can't intubate on scene. I'm not there. I'm home in my nice warm bed at night. You're the one on the scene making the decision. You have to make a decision, but understand the variables involved. Sometimes what they come up with is they stay on scene and do the intubation. And sometimes they do it en route. And sometimes they realize they need to get en route and can't intubate, so they drop an IG. And sometimes that means they have to use rocuronium to drop the IG. I'm okay with that.
So for our diehard, like you must maintain inline spinal immobilization, people that are listening, when would you tell your medics it's okay to loosen the collar and tilt the head back and put them in the ear-sternal notch?
I'm trying to answer this in a literature-based way, and we just don't have the literature on it.
Okay.
We have, I think, convincing literature that said backboards should be used for ramps, like ramps to roll things up on, as opposed to a ramp for a patient. And they should be used to fill up dumpsters. I have this beautiful picture of a dumpster behind one of our hospitals that is just saturated with backboards. It's beautiful, wow. Just where they belong. So we have plenty of evidence to say, get them off the damn backboard. You can raise the head of the bed. As a matter of fact, with head injuries, we really should be raising the head of the bed no matter what. Backboards don't help us. There's just not convincing evidence to say they don't need a C-collar. I can't say that. My suspicion is that they don't need a C-collar, that it doesn't do a whole lot of good, and that it has the potential to do harm, certainly restricting vascular flow. It's probably not cutting off carotid circulation, but I think it can be cutting off venous drainage, but there's not great evidence to say that. If you need to take the collar off to manage the airway, by all means, take the collar off. But it's a clinical decision, and I'm not there. So it's kind of hard to say. There's no science, and I can't tell you what to do on scene. So yes, there are trauma patients included in this data set, but the proportion of trauma patients decreased in the after group because they're so mindful of both getting off scene and avoiding hypoxia that they said, you know what, it's probably easier just to drop an i-gel and move. Clinically, that's probably the right thing to do.
Okay, so they weren't included.
They were included, but
I think they just had more selection bias.
Correct. Yeah, it just naturally decreased because of you can call it a Hawthorne effect. I call it an education intervention. They were more aware of it. So I just came up with this question. If your paramedics encountered a head injured patient, and you may have already answered this, I might just be a little confused. If they gave ketamine, and then they had a traumatic brain injured patient and the SpO2 was greater than 94%, do they still have the option to just paralyze and place the i-gel if they don't want to attempt intubation? Sure.
Okay.
Yep.
So it's kind of like a rapid sequence airway. Delayed sequence airway.
Yeah, it's a terminology thing, and without being a pedantic dick about the terminology, yes, it's an RSI. So exactly what he's talking about with RSI.
Facilitated airway.
You know what? No matter what we say, you're going to get added on Twitter about you weren't wearing gloves and you said this. Yeah, so they can absolutely do that. Ketamine paralysis with the intent to place an i-gel, absolutely.
Traditionally, delayed sequence intubation was reserved for patients who were agitated, who had a shunt, and who could not be oxygenated. They would not tolerate your oxygenation efforts. But you use delayed sequence intubation on all patients.
Yes.
Even if they will tolerate a non-root breather.
Even if they don't need it?
Yeah,
absolutely. I absolutely do. So this is one of the things that I had to take out of the Annals paper, my justification. They said that's not part of the science. And I'm like, yeah, but I want to say it. And they said, do you want to be published? Yes, sir. Please take it out. The reason we do it is not because of this is one of the pragmatic effects of being a medical director. What we do is not all science. We need to be science driven, but we also have to be pragmatic and we have to look at logistics. So we intubate we have 130 paramedics. We do about 28,000 transports and about 30 intubations a month. The majority of those are in cardiac arrest. We'll do anywhere from 3 to 5 of our RSI, DSI, non-arrest intubations. Now, you divide that out by 130, and you end up with about 2 to 5 intubations per medic per year. So that's not an awful lot. Mm-hmm. And the reason we try to do the same thing every time, the same way, is because there's just not enough experience. So if we're doing everything exactly the same way, we have more experience doing it that way, there are fewer variables, there's less to mess up. So the reason we do DSI on every patient isn't because they need it. It's for logistics reasons and training reasons.
I was surprised that your all's overall or even first pass success rate was so high considering they only get anywhere between 2 to 5 per medic per year.
I was a little bit embarrassed by our first pass success rate, honestly, because the time that we sampled for this study, it was actually on the low end. So I think we went from 84% to 86% first pass success. And we typically average anywhere from 88 to 92% first pass success. That's probably not statistically significant, but I'm proud of us, and it didn't make me as proud as I would have preferred. Not that it's about bragging rights or anything. I think one of the questions you had is how many opportunities do they have to intubate?
Yes.
So it's 2. 2 per patient, not 2 per medic, to be really clear. 2 opportunities at videolaryngoscopy, and then you do something else, whether that something else is BVM or iGel or surgical airway. It's one of those things, but it's not another attempted intubation. So I did another paper with Dr. Wang using the ESO data set. And we looked at something like 50 to 60,000 intubations over about a 2-year period. And I wanted to know what the cumulative success rate was. How many intubations did you have to have? How many attempts before you reached your maximal chance of success? And the answer is around 4. But it got me to look, and I got to see how many attempts we were making. There's always that one dude out there. There was that one dude who had
one more try.
10 attempts. 10. That's like a Roman numeral. 10. Not successful. So the first 9 were not successful. What makes you think you're going to be successful in number 10?
It's going to be the one man.
Yeah, and it wasn't.
I've got it this time.
You didn't. So yeah, we cut it off. And I'm sorry. See,
that's fine.
I do this. I tease him, and as soon as I get to see him wrapping up, I'm like, no, I'm not going to let you. So the other thing I probably ought to let you know is the reason we do this is I believe in it, and it's not just something I'm making my medics do because I don't think they're very good. If I didn't think they were very good, we wouldn't be doing anything. We'd be driving to the hospital rapidly. I think I have outstanding clinicians that I get the opportunity to work with. This is exactly how I do it in the emergency department. And I might add, it's a hell of a lot easier in the field than it is in the ER. Trying to convince some of my respiratory therapists to do this. I have to almost physically take the syringe of rocuronium and hold it myself. They are so ingrained to give them together because everybody else in the hospital does it that way. So it's a bit of a challenge, but I do it the same way in the hospital too. And I do DSI on every patient.
Really?
Yep.
You do personally in the hospital?
Absolutely. Whether they need it or not. I only work 1 shift a week, so I don't have that much experience either. And if I'm going to make such a big deal about asking my medics to do it, I think I need to do it the same way.
I'll combine these. Reoxygenation. How do you reoxygenate after the first attempt? Okay. And hypotension. You didn't mention how you guys manage hypotension, but I believe that in the after group, there was less peri-intubation hypotension. Do you care to explain?
Yeah, absolutely. So let me address the hypotension first. Yes, that is not in the paper because of it's a science paper. So I really had to focus on that bundle that was in place the entire period of time. When we rolled this out, one of my medics was really instrumental in this. His name's Archer Scherer. He was working with me. Then he left, flew for PHI, and now he's back working with us. They were implementing a very similar bundle at PHI right around the time we were looking into what are we going to do to avoid doing harm. So we implemented it together, and we knew right at the beginning that we need to avoid intubating hypotensive patients and hypoxic patients. I didn't want to put a protocol in place that said you can't do either all at the same time because I realized what a cultural change it was going to be. So we, from the get-go, said we're going to implement this in stages. The first year, we're just going to do our peri-intubation hypoxia protocol. The next year, we'll add in hypotension. So we didn't talk about the hypotension just because it wasn't there for the entire period of time. But absolutely. So you also cannot intubate a hypoxic or hypotensive patient until you fix it first. And we do that with fluids and vasopressors, whether that's norepinephrine or push-dose epinephrine.
Do you do that simultaneously with your when you give ketamine, you also focus on?
Yes.
Okay.
So the other question about reoxygenation, how do we do it? Well, it depends on whether they're still spontaneously breathing or not. So there is the scenario where the SATs are good, we give ketamine, they're still good, and then they drop and we haven't given rocuronium yet. If they're still spontaneously breathing and we're getting a good mask seal and good ventilations, and we can tell because we have Untitled CO2 on and we look at the pleth. And that is a stand-in. It's a surrogate measure, not a great one, but not a bad one, probably more accurate than pretending we can see chest rise in a 400-pound patient. We look at the pleth, and we have all that. We make sure the oxygen through both the nasal cannula and the BVM is at its highest, and then we start cranking up the PEEP, and we adjust PEEP to increase the saturation. Now, if they're not ventilating well, then we need to ventilate for them, so we'll gently ventilate. And if they're already paralyzed, I'm going to go out on a limb here and say they're probably not adequately ventilating on their own.
Yeah.
So we need to ventilate for them, and then we'll do that.
Okay. I think that
actually led right into one of the other questions, which is, so you have a very aggressive focus on resuscitation before intubation.
Yes.
And preventing desaturation at any point in time, aside from the initial contact, where
Correct.
they're already in the field
Bingo.
and just out there chilling with the SpO2 of 30.
Right, and we ought to fix that.
Yes, it warrants some attention.
Yeah.
So, at least in my experience, intubation is only half the battle. So you get the patient tubed. Super. What do you do now? So do you have an appropriate bundle? Do you have a similar bundle of care afterwards for like ventilator management or a post-intubation bundle of care?
So we do part of our protocol. So our typical approach is we give ketamine, and then we give rocuronium, then we intubate. And as soon as the ET tube is secure and we've verified and we're happy, we give another dose, full dissociative dose, 2 milligrams per kilogram of ketamine, both for sedation and analgesia. And that's the benefit. We get two birds with one stone. Exactly. And then we will continue giving ketamine anytime we think that they're starting to wake up, starting to have awareness or feel discomfort. We just whack them with more ketamine. We do not give any more paralysis. So in our system, paralysis equals intubation. If they're already intubated, do not give any more rocuronium. If you think you need to give them more rocuronium, that's because they need more sedation.
Yes.
If they're getting tachycardic, you need more sedation. And that just means more ketamine. So we don't have a vent bundle. We're rolling out a vent bundle now because in order to have a vent bundle, probably ought to have a vent. And we didn't have them. Now we do. And for the love of God, don't ask me which one. It's one of the O2 systems.
Oh, yeah.
Like 700 something, I think.
We've looked at that.
Yeah, we've looked at that exact model before.
So we have them. We have them on our command. So we have about 18 to 20 ambulances on the road, and we have 3 command vehicles. So the Lucas device is on the command vehicle, our cyano kit is on the command vehicle, and our ventilator is on the command kit. The expensive shit goes to the command. The stuff we can afford 3 of, but not, 20 of, goes on the command vehicle. They're simultaneously dispatched for high acuity calls, all cardiac arrest, things that we think are going to end up in an intubation. And then as soon as, if we miss it on that, well, it's a toe ankle. Oh my God, we got to intubate them. A toe injury or an ankle injury. That's where I was going.
I've never heard that terminology.
Yeah. This is what happens when a Texan tries to talk fast. It goes poorly. So if we're surprised and they realize they need to intubate, they'll go ahead and request the commander. So now that we have the ventilator, in our next budget year, we're going to try to get the court to allow us to put them on all vehicles. We're implementing a checklist for the vent. And we do the classic lung protective strategy. So we're using 8 per kilo to 14, and the tidal volume is based on age and weight, ideal body weight.
Okay.
Your standard MCRIT protective lung
absolutely. As a matter of fact, those videos might end up in our training materials.
The dominating the vent might end up being handed out.
My poor medics might see that. Yep.
So what are your options for an apparently difficult airway or an anticipated surgical airway? So if you have someone who maybe is alert but has maxillofacial injuries, and you can
let's say a tongue swollen to the size of Tennessee, and nasty
I just took
angioedema,
and now my tongue is the size of a softball.
Right? Yeah, that's bad. So number one, breathe like you breathe, because that's scary as hell. So you can certainly try to manage the airway in another fashion. The nice thing about that is it is scary as shit. The vast majority of those patients maintain their airway.
And they do fine.
It's distal tongue swelling. But oh my God, is that nerve wracking.
I had one fairly recently and she was starting to do that. And I was like, oh boy.
Yep.
It's
scary.
I was picking pieces of the seed out.
Absolutely. The nice thing is angioedema does not progress to airway obstruction. except in those cases where it does.
Except for when it does.
Right. So we manage the airway. We try not to do anything at all to the airway, but if we have to, and that's a clinical decision, there is no protocol for that. I have no idea how to write a protocol for that, so I don't try. We just hire smart medics, and we do education on this. So if they feel like they need to mess with the airway, that's fine. Go ahead. If you feel like you need to intubate, try to do an intubation. But while you're trying to intubate, make sure you have somebody else, scalpel in hand, bougie in hand, with your placement, hands on the throat, getting ready to go.
Ready to go.
And the problem that we found, and we train on the finger bougie or scalpel.
Scalpel finger bougie.
Thank you. I always get that order wrong when I'm saying it. So we train on that, and the thing that we found is when we've done them, we almost always do them too late.
The hardest decision is the decision to make.
Absolutely. Yep. And we are
I
no
said that
different.
as having never done one, but I spoke with one of my friends who's actually a fairly new paramedic who had to make that decision early on in his career.
Yeah.
And he said that was the hardest part.
It is absolutely the hardest thing to do. So yeah, we just tried to, any ENT doc will tell you, just cut them. I can fix that. Don't worry about it. Same thing with, we used to do early on in the days of needle decompression in the field. Oh my God, I don't want to do this because if they didn't have a pneumothorax, now they will, and they'll need a chest tube, and it'll be a huge hole in their chest. And oh my God, I don't want to do anything. You can stick needles in the chest all day long. Hell, especially in Texas where we're fat, half of the needles don't hit the airway anyway, the lungs anyway.
Have you seen the people that live in Kentucky?
They walk among us.
It turns out McDonald's are everywhere.
Yeah. It's a global phenomenon.
It is. So really we train on making that decision early. And if you need to do it, commit to it and do it early. And we're changing so we do a lot of training. Every medic in the system is intubating at least, one training session once a month. And that's how we're trying to compensate for 2 to 3 intubations a year. It's not as good as the intubation. Skill dilution is absolutely an issue. Mm-hmm. We do 2 medic trucks. From this standpoint of skill dilution, would be much better off if we had 1 medic per truck. Actually, you could probably say it would be even better if we had 2 EMTs on a truck and a paramedic in a fly car. But skill dilution is not the only thing you need to look at in the design of a system. We have to look at wear and tear on the medics. We have to look at additional decision making. We have to look at quality of life. We have pretty long tenured medics. We have people retiring from our system all the time because we pay them well and we treat them well and we don't run them into the dirt. So we have to think about things other than skill dilution. So it has to be a compromise. So we try to adapt for that by doing a lot of training. And in the training, we're now trying to get them to think about, okay, we're going to go ahead and do an airway. Here's our plan. We're going to do our normal bundle of care. It is entirely possible that this will be a more difficult airway than we anticipate, and we'll have to put in an iGel. And it's entirely possible that the iGel won't work. So our plan is that we'll do a surgical airway. If any of that happens, it's not because we failed. It is part of our plan. And we're trying to get into that mindset. I have no data on it. And with any luck, I won't have data because this should be a pretty infrequent occurrence. But that's what we're trying to approach it with. Okay.
Now, do you have any qualms with a medication-facilitated surgical airway? Because that's actually something that is... I know that sounds kind of like ballsy on its face, but there's a lot of... I come from a military background, so there's a lot of situations where there's actually protocols that exist for a conscious cric. So you have a patient with an expanding neck hematoma, or they can't be intubated from above for some reason like that, but they're still getting some sort of mentation, but not for much longer.
Sure.
So would this process still allow for administering ketamine or something like that and oxygenating the best way they can and then gaining positive control of that airway immediately? Just to make it a little bit easier on the patient and on you, because if that person's fighting you and you're trying to do a cric,
it might be a little more challenging.
Yes.
Yeah, no, I'm making the weird faces because I can't imagine us doing it without ketamine. So absolutely. Ketamine the hell out of them. If you're going to cut my neck, do me a favor and give me some ketamine. Yeah.
This is awesome. And this is actually...
That got cold.
This is pretty unheard of in Kentucky. I think one reason why that is because the way your medical direction system is set up in Texas. Because as I understand it, it's completely up to you.
Yes. So
not the case in Kentucky.
Correct. It's not the case in most states. So Texas is one of the last true delegated practice states. And allow me as a medical director to say, God bless Texas. It is so I'll give you an example. I was getting very frustrated with our patients in persistent VFib. We do everything we can possibly imagine to get them out of VFib. We do high performance CPR, continuous compressions. We don't interrupt compressions to intubate. We do dual sequence defibrillation. They've got an epinephrine. They get amiodarone, and 30 minutes into this code, we're still in VFib. What the hell do we do? Well, let's take them to the hospital. Well, that's dangerous. And okay, let's use the Lucas and then take them to the hospital. Well, great. What the hell do they do? Well, they just call them in the hospital because nobody's going to take them to the lab. Shit. Now what do we do? I'm going to give them esmolol. Is that going to work? Beats the hell out of me, but I'm going to give it a try. So what do I have to do? What committees do I have to go through? What state approval do I have to do? None.
You can just
do it. Yep. The one thing I had to do is make sure we can afford it. Hey, Mike, I asked my director, can we afford this? Yes. Great. Let's do it.
Did I mention an EMS utopia to us? And I don't want to concede that Texas is in any way good.
Absolutely. Yep. You know, you may have heard, but we're like our own country.
You in California, so you guys can duke that one out.
We are not likely to fall off into an ocean with one decent shake of the ground. So, God
most
bless
people
Texas.
that live in Texas come from California, right?
Oh, now it's on. I can throw you out this window. I live in Austin and right outside of Austin, so I think that's particularly true in Austin. I used to say Austin is turning into North Dallas, and now I say it's turning into North LA.
Oh, that's a scary thought.
Is that true? Most people are.
Well, actually, it would be Eastern LA, I guess, so far Eastern LA. Yeah, no, there are quite a few folks coming from California.
So on that nod, what steps and competence?
And California, by the way, is so. See how I timed
so
that?
Much hate.
I tried to see him get in. California is a beautiful, beautiful state. I mean, it's LA. It's 72 degrees year round. You can be in the mountains and go trail running and go skiing. You can be in the water and you can surf. I mean, they're beautiful people. Why would you ever leave? Don't leave. Stay there. Texas, you know, it's a drought. It's hot. Just stay there.
You need to.
Yeah.
You need to. Have you ever checked out the Red River Gorge?
The Red River around Taos?
No, in Kentucky.
Oh no.
Have you ever heard of it?
I haven't. I was thinking it was around Taos, New Mexico.
If you enjoy hiking, kayaking, mountain biking, rock climbing,
or all of the above,
yeah, it's the Grand Canyon of Kentucky.
Awesome.
Of the eastern United States.
Very green, I'm assuming.
Yeah.
Awesome.
Yeah. I think you would love that.
I'll have to take it. I love doing trail running.
The folks in the New River Gorge in North Carolina might fight you for that statement, but I'll be there fighting with you.
Okay.
It is the Superior Gorge.
I'll have to take a look at it. Yeah. I'm sorry. I digressed.
That's totally fine.
I'm trying to see if I can throw y'all off.
So if I worked for a service and I wanted to take the steps to get my organization to a point to where we could throw this in front of a medical director and be like, we want to do this. What steps and what competencies should we take? So we can take this to, for us, a state governing board that is often tough to persuade.
Yeah.
But for good reason. This is not something that should be approached in a half-assed manner.
No doubt. So here's my argument about intubation at all. If you're going to do it well. If you can't do it well, don't do it at all. That sounds pretty straightforward, but you really need to be good at this. We are taking away someone's airway, and this is the number one easiest way for paramedics to kill somebody. This is how we get clean kills. So you have to take it seriously and you have to do it right. So I am much more inclined to say paramedics should not be intubating at all than I am to say do RSI. I think if you're going to do it, you should do it right. Mm-hmm. The literature is really clear that intubation success is much higher with paralytics than it is without them.
Yeah.
It's funny you bring that up.
Do you hunt? You're talking about elk hunting. So let's say you're going to go elk hunting and you want to bring an elk down and you don't want to have the elk suffer. You want a quick kill. So you're going to go out and you're going to use a 22, right? Hell, let's use a BB gun. And let's shoot from 600 yards.
Airsoft guns?
It's about as effective.
Agonizing death.
Correct. So if you're going to go elk hunting, use the right tool. Use a 30-06. Don't use an airsoft. right? So if you're going to intubate, use the right tools. And the right tools are paralysis. Now, again, assuming we're not in cardiac arrest. Although there are some cardiac arrest you have to use paralysis on. And those would be effective compressions.
That's the thing that gets me is you're trying to convince a governing board that you can proficiently intubate, but you can only get your numbers so
you don't have the tools to actually do it.
Yeah, there's a very tangible brick ceiling. It's not even glass because the best way to do these things is to get better at these things. There's only so much I can do to get better at innovation with the tools that I'm given. I still get sideways looks walking into ERs with a nasotracheal tube placed. Like, what is that? We only see that in ENT.
Pretty good at that.
And unfortunately, we are.
Y'all are doing blind nasotracheal intubation?
Oh, yeah.
Yes.
Y'all are using ESO?
Yes.
Yep. Aha. So I mentioned I've been looking for these two. I've been trying to figure out where they're coming from. The last blind nasotracheal intubation I did was in Greenwich Hospital in 1991.
Nice.
Yeah. It used to happen all the time in EMS and in the emergency department. And then we got RSI and realized we don't need to do it anymore.
Also, CPAP really helped with that.
Yeah. So in answer to your question, it is really hard. I think what I would argue is that we need to make the case that peri-intubation or hypoxia is bad, and we need to do a good job of controlling the airway. Intubation is one way to do that. And if we're going to intubate, we need to do it right. We need to have waveform capnography with every breath. We need to position. We need to use apneic oxygenation, and we need to use appropriate pharmaceutical elements, which means a paralytic. And if you can't do those things, then I think you probably shouldn't be intubating at all. Now, keep in mind when you make that argument, the conclusion may be stop intubating.
This sort of swings both ways.
Yeah, it does. But the thing, intubation is, we always have this, you're going to get my laryngoscope when you pry my cold dead fingers off of it. That's because we're thinking about intubation in terms of us and our egos. We didn't sign up to do this job to take care of our egos, or at least we shouldn't have. We did it to take care of people, and it needs to be about the patient, not about us. So we signed up to be a profession, and we signed up to be servants, which means we put our patients' needs above our own needs. That includes our psychologic ego. So it's not about us, or at least it shouldn't be about us. It needs to be about the patient. And it may be if you can't do those things for whatever reason, just don't do it at all.
I'd probably be fine with rapid sequence airway. If they're like, hey, you guys suck at intubation, do RSA or DSA.
I would, but I would also like to be afforded the tools to actually do the procedure the right way.
Yeah.
You put it I can't add anything to that. That's a pretty damn good, just straightforward approach to it.
Should that be our closing statement?
I had a few more.
Okay. Not so fast there, buddy.
Hold the hell on for just a minute. What's the culture around your medical director and your standard QA and QI review? You mentioned the just culture. We actually started out with that. Do you think that that's a factor in your success of having people with a culture of we're not in trouble, but we are accountable? Like, you get your ass kicked when you deserve to have your ass kicked. But if you make an honest mistake, or if there is a system error, do you feel that helps these situations? Having that culture of we're going to be accountable for our mistakes and we're going to learn from them. We're going to alter our system, but also that I don't have to worry about getting screamed at for the tiniest thing, or even when it's not a tiny thing, but it was a human.
Yes. Now, in some places, you do worry. It's like, oh my God, you screwed up. I'm going to send you to the medical director. Okay. So I never, ever, ever want my medics to be in a situation where they feel like talking to me about something as a punishment. I think that is horrendously self-defeating. If I yell at people, then they're not going to come talk to me. I mean, I may have mentioned we hire smart people. We put them through pretty extensive testing. The people that work with us are smart. If I yell at them, it's going to take them about 3 nanoseconds to realize, well, that was unpleasant. I don't think I'm going to do that again. We don't hire the type of people that continually reach out and grab the hot stove until they keep burning themselves. They're going to do it once and go, I'm not doing that again. So I don't ever yell at people for missing an intubation. I don't yell at them for the patient getting hypoxic. I think that is incredibly self-defeating, and not just about airways, about anything. And that's not to say I don't yell. Ask the people who have an office around me. I yell at my computer so loud. Everybody, I have an elk up in my office, and that I almost reanimate the elk. I'm yelling so loud. I get frustrated with my computer
I've seen
or programming.
The elk in one of your YouTube videos.
Yes,
it's absolutely it's the make CPR great again elk.
Yep.
But yelling at people, I think, is just counterproductive. It's a stupid concept. So you ask about quality improvement. I'll tell you how the process we use. So every intubation is reviewed. We look at it. We read the chart, obviously, but we also look at, Phillips calls it a HIC file. It's the data file. So we open up multiple challenges. One of my partners, John Gonzalez, is the one who does this. He looks at the waveforms and maps them out. So he's looking at the systolic blood pressure, diastolic blood pressure, heart rate, pulse oximetry level, respiratory rate, and end-tidal CO2. And then he matches that with the time we gave ketamine, the time we gave rocuronium, and calculates, was it a first pass success? Was it a first pass success without hypotension or hypoxia? And that's a metric that we're working on. So everyone gets that. And then we'll send you a report card and let you know how it worked.
Do you have like a local form that you fill out for each intubation, or do you try to use the searchable?
So we do both. I have an email, an ad hoc report in ESO, that I wrote that comes into my mailbox every day, and it's just month to date. So I have about 15 of those on different criteria. And that is what we use to go in and identify the patients and look at them. In addition to that, we have this isn't the ultimate technology answer. There are other ways that I would like the system to work. But medics will go on to our SharePoint and they fill out a form for every intubation that asks them additional information. One of the things that I ask them is, we look at starting SAT, ending SAT, whether you used all these things, what the indication was, obviously whether it was successful. But we ask them, what would you tell your colleagues based on what you've learned from this airway? And we take that. It's just free text. And we take that and we incorporate that into our education.
That's very clever.
So we do that on all of our that's our QI process, but it is absolutely non-punitive.
I would say that having that in place before you even look at doing a program like DAI or screwing around with paralytics is an absolute prerequisite.
Absolutely. I know that there are a lot of systems where there is this battle between operations and clinical, between administration and medical director, between the medics and the medical director. And I think if you're in that is a toxic situation that is designed to generate a bad outcome. Not to mention, it's just a shitty place to work. I mean, why would you want to work in a place like that? The reason I love my job so much is I work with friends. We get along great, and we all are working. We're rowing this boat in the same direction. And anything other than that is just counterproductive, and it's not fun. I think we ought to have fun at our job.
I absolutely agree. So the last question I had was the reality of a lot of our listeners, and at least for Floyd and I, is we have no medication-assisted options for intubation. So even if I can't do the full DAI, what are some other airway or resuscitation pearls that I can take away and use on my next shift?
So the key thing is the term I'm using for this concept is avoiding peri-intubation hypoxia. Well, if you're not intubating, then you would say it doesn't apply. But a better term, maybe a more broad term, is just avoiding crappy airway management. So the majority of the toolbox we use does not involve a laryngoscope. It doesn't involve rocuronium. So positioning, turns out it works, and you don't need any drugs for that. Apneic oxygenation works. Nasal cannula oxygenation as an adjunct to a face mask, or better yet, some type of non-invasive positive pressure ventilation works. If you're going to make a seal, there's nothing ALS-y about making a seal. 2 hands, thumbs down toward the feet, lift the mandible up, don't push. That's a BLS skill. We don't teach people how to do that. Using end-tidal CO2, there's nothing druggy about that. Our EMTs should be using that also. So all of those things are BLS skills. They're better ways of managing the airway that don't require an intubation or rocuronium or succinylcholine or, whatever you use.
You placed the CO2 cannula on. Why don't you just put the mainstream in between the BVM and the mask?
So we do, but we do both.
Okay.
And the it's a timing thing and a logistics thing again.
Okay.
The reason we have the Entitled CO2, the nasal prongs, is that's what we started with. Most of these patients, we're going to do a trial of non-invasive positive pressure ventilation. So we'll just hook up the nasal prong. Maybe they start off with just a non-rebreather, and we add that in. Once we move over to doing our CPAP or like we're getting ready to intubate, then we also have the inline, and we'll switch it over to the inline. So again, it's all about logistics. The key thing, though, is before we push the rocuronium, we're going to be on the inline, because right now we're not using CPAP or BiPAP as part of our DSI. And the reason is because we have 3 ventilators as opposed to 20. Mm-hmm. Once we get the ventilators on the truck, we're probably going to switch over to just using BiPAP for our process. And I kind of lied when I said I use this exact same process. I cannot convince my respiratory therapist that you don't have to squeeze the BVM to deliver oxygen. Yeah. I mean, I've tried, I've given them literature. It doesn't work. So I say, screw it and just put them on BiPAP. Once we have the ability to put all of our people on BiPAP, we'll do that, and we'll use the inline there. But the thing I like is when you move from BiPAP, you disconnect the mask and connect what's the thing we're putting in? The ET tube. Yeah. So that you have waveform capnography with a first breath. Nice. And that's the way to confirm an ET tube. I listen to breath sounds, but it's, sort of because I feel obligated to.
Yeah.
Yep. Sounds like a diesel engine. Doing this. Exactly. The Entitled CO2 is where the money is.
Yeah, that's what we tell our folks. Anytime you bag a patient, use Mainstream that way. After you place whatever airway device you're placing, you just pop it off and put it on.
Absolutely.
I just go ahead and put it on the bag at the start of the shift.
Mm-hmm. Yeah.
Because I'm really bad about forgetting things.
Yep. Yeah. Add in the PEEP too.
And then when we get on scene, shit's going crazy, and you ask someone else to ventilate with a BVM, and chances are they're not going to remember to monitor CO.
Absolutely.
Awesome. I think that was an excellent interview.
Fantastic.
You're super approachable guy, so we encourage our listeners, if they have any questions, to reach out to you directly. If
Absolutely. Okay. Yeah, please. So you can get a hold of me in a couple ways. If you're on Twitter, I'm at Dr. Jeff Jarvis. That's not at Jeff Jarvis, who's like a literary critic and says really weird things. And it's not at Prof. Jeff Jarvis, which is a satire account of the at Jeff Jarvis, who is a literature critic and says really weird things. I ended up in the Washington Post because of that. As I first got on Twitter, there was this battle between them, and somehow people are trying to at these people because they're saying stupid shit. And they're ending up going at Prof. Well, that's that doctor thing. At Dr. Jeff Jarvis. And I'm sitting there still trying to figure out which end of Twitter is up. And I get this call. Hello, this is so-and-so from the Washington Post. How do you feel being mixed up in this? And they made me sound like some complete,
Are you secretly behind at Thanks Foman?
I don't think I've seen at Thanks Foman. That can't be me.
Holy shit.
I guess I'm going to have to.
Yes.
Is that a satire account?
Oh, yes.
Oh, man. No, I'm going to have to take a look at that.
So, it was a pleasure having you on the show today.
And I'm sorry, the other way you can get a hold of me is by email. It's jjarvis@wilco.org. WILCO.org. And you can also take a look at us on YouTube. Just search for Williamson County EMS. We put all of our online training up onto YouTube. That's probably the best way.
You guys have some awesome King Vision in-service videos that, if we were going to go with King Vision, we would probably make our
shamelessly
folks watch all those.
I absolutely do. And keep in mind that it's not just about the King Vision. So those techniques work for a lot of those techniques are useful for anything, not just the King Vision.
Any kind of hyperangulated blade with a track?
So not just that, because as far as I know, there are really only like maybe 4 of them.
Okay.
Just DL in general. So one of the tips is hold it low and light. That really applies to DL also.
Or VL?
Or DL, okay. VL, anything.
Gotcha.
Hold it low and light, adequate positioning, use suction first. All of those things apply to very, very broadly. Some of them are very specific to a hyperangulated channeled blade, like rotating the ET tube in the channel. Well, if there's no channel, it's kind of hard to rotate in a channel. But the concepts are the same. If you're using a hyperangulated blade, a glide scope, or CMAC with a D blade, or McGrath with an X blade, any of those hyperangulated, you need to use a hyperangulated stylet, and you still rotate the tube. You just use a different technique. But the concepts are still the same. And by the way, I did not have leukemia in that video. I'm bald. And it wasn't because I had chemotherapy. We did a shave your head for one of our medics who did have cancer, so I shaved my head.
Do you have anything else to add?
I don't think so. Thank you all very much for the opportunity to talk about this. I think peri-intubation hypoxia and hypoxia in general is really important. I'm a big believer in pre-hospital intubation, but I think if we're going to do it, we have a responsibility to do it right. And I just appreciate the opportunity to get some techniques out there to help us do it right.
And I would especially like to thank you for doing this, because there seems to be an endemic line of thought that it's okay, we'll get the tube really quick.
Yeah, no, you won't.
And they're in the 80s. They're not, at least they're not 60. We can do this. Hand me the nasal tube. We can get this.
Yeah, they're in the 60s. At least they're not in the 40s. Yeah, in their 40s. At least it's not in the 20s.
And I think one of the big takeaways from this is taking your damn time.
Yes.
Have a process.
Yep.
And train on it.
Yeah.
Give a shit about what you're doing and give a shit about the people you're taking care of.
Absolutely.
And the technicalities of your DAI process, I really like. But I like the principles that it stands for more, because I can take that anywhere. Take it to systems management. We can take it to high performance CPR. And we can really affect great positive change if we would embrace this more as a profession.
Sure.
Especially in our your high acuity, low frequency type of events, because we're not allowed to do surgical cracks in Kentucky because we're essentially not trusted with it unless you fly in a helicopter.
I will tell you that that's entirely appropriate, because the anatomy of the airway is different at altitude than it is on the ground. So I can understand why they would do that.
Every time I've ever been in a helicopter, I felt this weird tingling in my throat, and
clearly.
then shit just changed.
Absolutely. It's also different inside the ER door than it is outside. Physiology is completely different. It's
the damnedest thing. When you cross the threshold to the ER
the door, it's different.
Everything changes.
Oh, yeah.
And then when I get a shit show transfer, the assumption is the moment we cross, my ambulance is actually a force field.
Absolutely.
The patient stays in stasis the entire time for an hour.
Absolutely.
And then I magically get at the ER and they press play.
It's true. So the one other plug I'll have, I would love it if you would read the Annals article. It's implementation of a clinical bundle to prevent peri-intubation hypoxia. But that is there. It's free for 90 days. That firewall is going to come up. I'm writing an article essentially on this, and less of a scientific approach for EMS World that should be coming out. I believe it's the October edition. And then I'm going to have a blog post on Foam Frat that Tyler is going to post that explains why we do the things we do, why I took DL off the truck, why we do this thing on everybody, whether they need it or not.
When's he posting that? Do you know?
I've asked him to hold on to that until the EMS World article posts, so I'll be able to reference it. So sometime in October, I think.
We'll link to the Annals article, at least, in your YouTube channel and stuff on Curbside to Bedside. So, folks, that's it for now. It's an honor having you on the show. If you have any questions for us, shoot us an email at curbtobed@gmail.com and find us on social media at curbtobed. Thanks for listening.